Please join me in welcoming our esteemed 2023 Kreuter Katz speaker, Dr. Leandris Liburd.
Thank you so much, Leah. Leah was a student intern with me one summer, and she did some phenomenal work for our office, and I knew that I would find her again in the place where she is as an assistant professor on her route to full professorship and other great work. I also want to thank Dean Lynn and congratulate you and the School of Public Health on your 10th anniversary. And good afternoon to everyone who has gathered here today. I cannot begin to tell you what an honor it is for me to deliver the 2023 Kreuter Katz Health Equity Lecture. I have been privileged to spend my entire public health career addressing health disparities and pursuing health equity. To have been given the opportunity to share this platform with such distinguished public health scholars and national leaders is truly humbling. A little known fact for those of you who have just joined us in the room is that now more than 30 years ago, Dr. Kreuter was the person who recruited me to come to CDC. I came as a staff fellow and thought I was coming for 2 years and would go back home with the CDC experience on my resume. Instead, after 2 years, I was offered a permanent position and have enjoyed a public health career that I could have never imagined. Today adds another milestone to a career for which I had no frame of reference to imagine the possibilities. If I had been hired by the Richmond City Health Department or the Virginia Department of Health for this same period of time, my family would have been very proud and viewed me as a big success. So I want to publicly say thank you, Dr. Kreuter, for giving me a big tent from which to expand and excel. So I titled my talk today, Health Equity at a Crossroads. I was very intentional about not saying at the crossroads. And so this afternoon, I will share some historical reflections on public health's commitment to health equity through the lens of the principal influencers on my professional journey. I will also highlight some of the work of CDC over the 35 years since the establishment of the Office of Minority Health, which over the years has been renamed the Office of Minority Health and Health Disparities and the Office of Minority Health and Health Equity. This year, the office was moved into an expanded focus in what is now the Office of Health Equity. In this historical moment, we are experiencing a bit of turbulence in the health equity movement. But I hope to demonstrate that these kinds of crossroads, or what my colleague Jeff Hall calls a roundabout, are not unprecedented, but require that we be thoughtful and strategic. The question becomes, how do we plan for and then steer our research and praxis in a direction that sustains and advances the aims of health equity into the future? From my public health training in health education to the public health geniuses who have influenced my career over the years, I will highlight perspectives grounded in health education, health promotion, and social determinants of health that underpin our contemporary work in health equity. I want to acknowledge that there are dozens of scholars and practitioners who have been and who are consequential leaders in health equity, but it is beyond the scope of my lecture today to do justice to their contributions and their legacy. So coming straight from my undergraduate program, I enrolled in the now Gilling School of Global Public Health at the University of North Carolina. The chair of our department at that time was Guy Stewart, an anti-apartheid immigrant from South Africa. He was a clinical psychologist who was recruited to UNC from UCLA in 1970 and served as chair of the Department of Health Education until 1984. His leadership brought a fresh perspective and a new focus on the social causes of disease. As Health Education Department Chair, he introduced the action-oriented community diagnosis, a strategy he and other South Africans developed in the pre-apartheid 1940s. It has since become a cornerstone of the UNC's approach to community health education. A central theme of his work was that human behavior is part of a complex behavioral system that involves psychological, social, and cultural antecedents that educational and social scientists are only beginning to understand. He emphasized the central role of culture in health, as he argued strongly that a primary reason for the failure of public health programs among the so-called hard to reach in the United States is because practitioners incorrectly assume that they understand the culture of the target community. And I would argue that we are still struggling today to fully embrace that. In his approach, improved health, increased community competence, and social change are all outcomes of effective community development. He advocated, however difficult, that the role of the practitioner in community health be guided by as many of these themes as possible. The other person who was influential in my development as a public health practitioner is Dr. John Hatch. Dr. Hatch is best known for his pioneering efforts to bring health education into the Black church. He understood that the Black church can exert a wide-reaching influence in the lives of Black Americans through changing the behaviors, attitudes, and knowledge of individual congregation members, as well as through mobilizing changes in the larger social order. Dr. Hatch's leadership in the community health centers movement and faith communities has been a model for decades as he explored ways for health professionals to leverage Black churches in promoting health and preventing disease. His work with Dr. Jack Geiger in the 1960s at the Delta Health Center in Mound Bayou, Mississippi, proved the value of community health centers, especially in Black and rural communities. And I want to just share a quick story from Dr. Geiger. He came to visit us once while I was a student, and he told the story of working in Mound Bayou, and he would write prescriptions for food. And the Bureau of Primary Care would push back on him and say, "What are you doing? We don't do that." And he said, "The last time I checked, the treatment for malnutrition was food." And so today we have food as medicine, right? We have actual coverage in some instances for that, right? So as you are listening to me, I want you to hear the crossroads that we are continuing to move through. And let me just lastly say that Dr. Hatch was the first employee who was hired and served as Director of Community Health Action at the center. And he is credited for selecting Mound Bayou, Mississippi as the location for the first rural community health center in the nation. Now, it is almost impossible to categorize, summarize, or miss the profound influence of Dr. Larry Green on health promotion, who is actually here with us today. Dr. Green is the founding head of the Division of Health Education at the Johns Hopkins Bloomberg School of Public Health. He was appointed by President Carter as first director of the Office of Health Information, Health Promotion, Physical Fitness, and Sports Medicine that coordinated the development of the Healthy People reports, which continue and still inform the nation's public health policies today. He is the former vice president and director of the National Health Promotion Program of the Kaiser Family Foundation and co-creator of the Pre-Seed, Proceed model along with Dr. Kreuter. He wrote in 2000 that health education and health promotion have a long history of being organized around settings, such as healthcare, workplaces, and schools, which are, as he stated, major social structures that provide channels and mechanisms of influence for reaching defined populations. Dr. Green predicted a new emphasis on concerns with the environment and with housing and other conditions of living that shape the health-related lifestyle of individuals and families in the community. And he was, in his work, a forerunner to what we understand now as the social determinants of health. But I want to also reference in 1986, the first international conference on health promotion was held in Ottawa, Canada, and produced the Ottawa Charter for Action to achieve health for all by the year 2000 and beyond. The Ottawa Charter identified these fundamental conditions and resources for health: peace, we're in 1986, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity. During these same periods, two European researchers with decades of work highlighting associations between social inequalities and health are Dame Margaret Whitehead and Sir Michael Marmot, who I've had the privilege of spending time with him in London, inviting him here to work with us as we've tried to push forward a social determinants of health agenda at CDC. And Margaret Whitehead, who currently chairs public health in the Department of Public Health and Policy at the University of Liverpool, was also the founding head of the World Health Organization Collaborating Center for Policy Research on Determinants of Health Equity. In 1992, she wrote an article to raise awareness of the concepts and principles of health equity in Europe. She defined in health inequities as differences in health that are unnecessary, avoidable, unfair, and unjust, 1992. Sir Michael Marmot, who is professor of epidemiology and director of the Institute of Health Equity at the University College London, is a world-renowned researcher known for his work highlighting the relationship of social determinants to health and mortality. The central thesis of his work is that social injustice is killing on a grand scale. And this underscored his efforts to make the evidence-based case for improving health outcomes by reducing inequalities. I would be remiss to not mention the extraordinary impact of the landmark report of the Secretary's Task Force Report on Black and Minority Health, also known as the Heckler Report, which was led by then Secretary of HHS, Margaret Heckler. The report elevated minority health onto a national stage, because it was the first time the U.S. government comprehensively studied the health status of racial and ethnic minorities. It continues to serve as a driving force for ending health disparities and advancing health equity in America. So whether the framing was from the standpoints of health education, health promotion, or the social determinants of health, the central goal of health equity has been and continues to be to eliminate largely preventable health disparities in populations that bear a disproportionate burden of health disparities and health inequities. Stephen Thomas and other researchers at the University of Maryland examined 3 generations of health disparities research in a 2011 publication to understand data trends, factors driving disparities, and solutions for closing the health disparities gap. They proposed this health equity action research trajectory, or what they gave an acronym of HEART, as a platform for 4th-generation research to achieve health equity. This model is grounded in critical race praxis, using comprehensive interventions to address race, racism, and structural inequalities, and advancing evaluation methods. So public health researchers and practitioners have long recognized the impact of non-health factors on health outcomes. But events since the COVID-19 pandemic have both elevated and accelerated attention to the structures that either facilitate or hinder population health. Over the last 4 years, the world, our nation, and our agency have been waking up daily to systemic inequities. For the first time in 2021, CDC declared racism a serious public health threat. Over 200 jurisdictions around the country similarly called out racism as a public health crisis. This, however, was not the first time public health researchers have both observed and documented the impact of racism in health, but there wasn't a viable national platform or comfort, particularly in governmental public health, with taking this on as a policy or practice priority. Some would argue that in 2020, the combination of the social protests, a global pandemic, and the devastating impact of COVID-19 on communities of color and other marginalized and disenfranchised groups raised voices that may have been silent or muffled in the past. Again, there are many national thought leaders and scholars that I could acknowledge, but the persons I list here have had a great influence on me and the work we've been doing lately at CDC. Daniel Dawes is the director of the newly established Institute of Global Health Equity at Meharry Medical College. He is a nationally respected voice in the health equity movement, and his book, The Political Determinants of Health, examines the drivers of health inequities and how policy and politics influence the conditions that generate health outcomes, including pandemics, wars, and other threats. Dr. Brian Smedley is another national thought leader in the field of health equity and currently serves as an equity scholar at the Urban Institute, where he conducts policy research to address institutional and structural racism and their role in health and healthcare inequities. His book, Unequal Treatment: Confronting Racial and Ethnic Disparities in Healthcare, explores how disparities in treatment can arise in healthcare systems for persons of color. Two additional thought leaders in health equity I want to mention are Doctors Aletha Maybank and Kamara Jones, who have also been instrumental in moving the health equity discourse toward issues of structural racism and other drivers of health inequities. Dr. Aletha Maybank is the current Chief Health Equity Officer and Senior Vice President for the American Medical Association, where she focuses on embedding health equity across all the work of the AMA and leading its Center for Health Equity. In her prior role as the founding Deputy Commissioner for the Center for Health Equity at the New York City Department of Health and Mental Hygiene, she strengthened equity efforts and transformed organizational culture to support the success of the center. She was instrumental in infusing equity at the neighborhood level and advancing the department's place-based approach to addressing health inequities. Dr. Kamara Jones is an anti-racism thought leader and activist, and her work on race-associated differences in health outcomes goes beyond simply documenting those differences to vigorously investigating the structural causes of the differences. You may be familiar with her theoretic framework for understanding racism on 3 levels: institutionalized, personally mediated, and internalized. She presents this framework through storytelling about a gardener with 2 flower beds, rich and poor soil, and red and pink flowers, which illustrates the relationship between the 3 levels of racism and helps to guide our thinking about how to intervene to mitigate the impacts of racism on health. Dr. Mary Bassett, whose influence is widely known, is currently faculty at the Harvard Chan School of Public Health. She has dedicated her career to advancing health equity and overcoming systemic racism. Prior to her appointment at Harvard, she served as New York City's Commissioner of Health and worked to ensure that every New York City neighborhood supported the health of its residents, with the goal of closing gaps in population health across the city. Her 2015 article in the New England Journal of Medicine, #Black Lives Matter, a challenge to the medical and public health communities, reflects her perspective as New York City's health commissioner, encouraging critical dialogue and action on issues of racism in health. As I was reading Dr. Bassett's article, I was reminded of a meeting I was in, I think it was in 2016. I was in Los Angeles, and PolicyLink had convened this very large health equity conference. And one of the panels were members of Black Lives Matter. And they were, telling their story. And the moderator asked this question. He said, "How are you all pacing yourself?" And one of the young men said, and I quote, "We don't have to pace ourselves." He said, "The wind is to our back." And I remember thinking to myself, the wind's never at your back with what you all are doing. And so we have to remain diligent and know that the wind is not at your back. Dr. David Williams, a global icon, is a St. Lucian, an American social scientist whose research has enhanced our understanding of the complex ways in which race, socioeconomic status, racism, stress, health behaviors, and religious involvement can affect physical and mental health. The everyday discrimination scale that he developed is currently the most widely used measure to assess perceived discrimination in health studies. So how has this collective body of work informed what we have been doing at CDC to advance health equity? First of all, this year marks 35 years since the initial establishment of an Office of Minority Health at CDC. Over the more than 3 decades of what is now the Office of Health Equity, there have been numerous legislative, programmatic, and scientific achievements that have helped us sustain federal initiatives to address health disparities. Most recently, our office provided leadership, as Dr. Scott already mentioned, in creating the first Chief Health Equity Officer role and function in an emergency response. We co-created the agency's first health equity science and intervention strategy, known as CORE, and I will say more about it. And we launched an internal anti-racism and health sprint team to examine how policies and practices might unintentionally perpetuate inequities. We are particularly honored by the congressional renaming a year ago of our undergraduate public health scholars program to be now the John R. Lewis Undergraduate Public Health Scholars Program. So at CDC, we define health equity as this. It's the state in which everyone has a fair and just opportunity to attain their highest level of health. But to achieve this, it requires focused and ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and ultimately eliminate preventable healthcare disparities. In 2021, CDC launched an agency-wide strategy that we call CORE to integrate health equity into the fabric of all that we do. So, CORE, what does it stand for? The C is for cultivate comprehensive health equity science. O is for optimize interventions. The R is for reinforce and expand robust partnerships, because public health and medicine cannot do this work alone. And E is for enhance capacity and workplace diversity, inclusion, and employee engagement. So after the launch of CORE, across the agency, we asked all of the national centers, institute, and offices, or what we refer to as CIOs. I may slip up and say CIO, so you'll know what I'm talking about. We asked all of them down to the division level to submit up to 4 health equity goals. And we received over 150 catalytic goals that either advance health equity science, are intervention focused, are a combination of science and interventions, or have cross-cutting goals that facilitate policy guidance and systems changes that support agency-wide standards and implementation across a wide range of program areas. The 159 goals fit into 7 overarching health equity themes, and you see them here. 3 of the themes were focused on science, 1 of the themes focused on interventions, 2 themes focused on partnerships and coordination, and 1 theme was focused on our workforce and the workplace, so that we might bolster CDC's capacity to pursue health equity and improve internal diversity, equity, inclusion, accessibility for all employees, and belonging. So as previously mentioned, in February of this year, as part of a larger reorganization, CDC created the Office of Health Equity. And 3 offices make up the Office of Health Equity. They are the Office of Minority Health, the Office of Women's Health, and a new office that we call the Office of Equitable Population Health, which is where we will have an intersectional focus on people with disabilities, people who live in rural areas, and people who identify as LGBTQ+. The mission of our office is that we exist to ensure that health equity is embedded in an all-of-public health approach to overcoming persistent health disparities and health inequities across a range of population groups that disproportionately experience poor health outcomes. And our vision is consistent with our definition, which is that all people have the opportunity to attain the highest level of health possible. This year, we also developed what we call health equity intervention and action principles. So there are 7 overarching principles that should underlie and inform interventions to advance health equity. We're trying to get people away from arbitrary, non-literature-based decisions about what health equity is and when you're doing it. So while these are listed as separate principles, it's important to understand that they are interdependent and reliant on one another. And so based on our study of the literature, these are essential principles that will be needed to advance health equity, right? So first of all, we must embrace equity as the foundation of organizational commitments, policies, and practices. So we must lead with health equity. We must embody anti-racism and anti-oppression in all aspects of the organization and its interventions. We must establish and maintain the right infrastructure to be able to advance health equity. And we must communicate effectively to advance health equity. We must engage communities and mobilize partners to enable effective and sustainable organizational efforts. And we must advance health equity in the context of structural and social determinants of health. And lastly, we must apply equity-oriented and equitable evaluation approaches to monitor and evaluate progress towards achieving health equity. So, as I am coming to a close, what are the opportunities ahead of us? And I could also say, what are the challenges ahead of us? And how do we maintain the integrity of decades of work that have evolved to bring us to this critical juncture in the work of health equity? Community engagement, I have to say, it should be a given. But what are the opportunities that we have to increase community engagement, including being able to work with and fund communities directly? Taking a syndemic approach. How can we be more strategic and coordinated in our program planning when the goal is to reduce and eliminate health disparities in communities that experience a broad range of health disparities? So as you all know, CDC is what I describe as categorically organized. We're funded by disease categories, and our national centers, institute, and offices receive funding in that way. And so we are putting monies out through different mechanisms, but to address the same populations, right, that have the same problems. So how can we start to think syndemically? Leveraging policies, authorities, and establishing agency standards. So what would those agency standards be? What are the policies and practices that are needed to effectively integrate and institutionalize health equity in our science and programs? And then always we have a concern about data and data standards. So how do we leverage existing policies and authorities to improve data standards, collection, surveillance, sharing, and dissemination? And then lastly, but certainly not least, in terms of health equity science, How do we build the evidence base using equitable approaches? So in closing, we can think of our ongoing work to advance health equity as a roundabout, in that a roundabout promotes a continuous flow of traffic. Unlike intersections with traffic signals, drivers don't have to wait for a green light at a roundabout to get through the intersection. Traffic is not required to stop, only yield. So the intersection can handle more traffic in the same amount of time. It goes without saying that there is still lots to do. We need lots of cars in the roundabout, and I am confident that working together, we can do it. So I want to invite you to connect with us. We have a quarterly newsletter that we call Health Equity Matters that right now I think goes out to about 30,000 people. We have a Health Matters for Women monthly newsletter. And we have a Conversations in Health Equity blog. And we also have a Twitter account, so you can follow us on Twitter. And with that, I want to say thank you for your attention. And I look forward to the questions and answers, and especially the answers you all will have to the questions that I have raised. Thank you very much.
Thank you so much, Dr. Liburd. Especially thank you for your leadership over not days, weeks, years, but decades, and for making the time to be with us here this afternoon. Can we have just one more round of applause for Dr. Liburd? So I have the honor of being the facilitator of questions, and fortunately, a number of questions were provided online before today, so thought we'd start with those, and then if there are those of you in the audience that have questions, we can get to those as well. Fortunately, unlike most speakers, you respected the fact that we would have questions, and you didn't finish with like a minute left to say, okay, now let's have questions. So we really appreciate it. So actually, similar questions or related questions from two students, Jacqueline Jordan and Inga Rogers, and I'll read them both to you because I think they're related. The first is, how do we as public health students promote health equity at the societal, organizational, policy levels? So that should be a quick answer, right? And the second is, what positions or roles in public health offer the greatest opportunities to advance health equity?
So, this week, right, was the American Public Health Association meeting in Atlanta. And I hope as many students as possible that you were able to take advantage of at least some of that, because it gives you a chance to hear about, work that's going on around the country. And I think it gives you a chance to really explore like the breadth of public health and where you can plug in terms of, influencing health equity policies, research, and practice. I also think as you are, doing your work in terms of, master's theses, doctoral dissertations, this is a wonderful time to really delve into the substance of that and really start to think through solutions, because that's where we are. What I was sharing with you is the issues that we grapple with in health equity, we've been grappling with for a long time. But it's not a time to retreat. It's a time to really lean in and consider what it is that we haven't done. So that's how I would, respond to students and what you can do. I think in terms of positions. You know, I think in a perfect world, you should be able to plug in health equity everywhere. I mean, we're working hard to make sure that our science and like CDC's concept of science, it is evolving, but it's certainly focused on the foundational science of epidemiology. But we have social scientists. We have more and more data scientists, people who are doing predictive analytics and modeling and things like that. There is a growing focus on artificial intelligence where we desperately need some equity perspectives integrated in that. So, you know, I think if you're studying epi, if you're studying health behavior, if you're certainly studying, you know, statistics, we need, you know, new models and new ways of really capturing how the social context is influencing health behaviors and risk for certain, you know, health conditions.
Great, thank you.
And health communications, always.
So the next question, also from a student, Rasan Overton, is what are some key strategies for disseminating and implementing health equity approaches throughout agencies and organizations? And you certainly touched on some of that in your talk, but to the extent you'd like to elaborate on that.
Yeah, so, you know, we do things like webinars, we do lots of those. We provide, you know, technical assistance directly, you know, to parts of the agency who request it. We're building like communities of practice where we bring people together who have a focus on health equity. And, you know, we're there to mentor and support each other in that work. So, and like recently, there's been a number of health equity supplements that have been published, some focused on racism and health. So those are things that we're doing. And I think whenever you have an opportunity to create a forum like this where we can talk to each other about these issues and be candid, I think that's always helpful.
And then the next question is, and I'll paraphrase it, is how are you thinking about sustainability, given political cycles,
Right.
given the fact that you indicated that the wind is in fact not at our back? What do you see as the main kind of challenges and opportunities around sustainability for this work?
So, you know, when I think about this, I think about the one variable, which is health disparities remain. They are costly, and they are costing the entire society. So I always, you know, want to like put a stake in the ground that we need to improve the disparities. And that is not, for me, political. It's public health. So I think we need to continue to do the work of reducing those disparities.
Thank you. So from one of my environmental health colleagues, Dr. Greenwald, he's wondering what your thoughts are about potential solutions to green gentrification, the problem of improving environmental conditions in historically disinvested communities that lead to gentrification and displacement, and how do we protect legacy populations in a way that they can benefit from the new amenities?
Yeah, let me say I haven't spent much time in that space, and so I don't know what I could, I wouldn't be able to say I wouldn't have a good answer for that.
That's fair.
Yeah.
We'll take that up with you later, Roby. And then one more question before I open it up to any others. So if you are interested in answering a question, there's another, just raise your hand, there's another microphone back there, and we'll get to you. But this is a question about what you see as the potential opportunities for we at the GSU School of Public Health to partner with you to help build CDC capacity as the agency works to meaningfully operationalize and integrate health equity.
You know, when I think about Georgia State University, and I think about that you all are in, the heart of Atlanta, and we need lots more expertise around how we do this work in urban centers, like Atlanta, and how we can piece out, if you will, the work that needs to be done. Like, what's the policy work that needs to be done? What's the practice work that needs to be done? What's the data work that needs to be done? And so, I can see our office partnering with your school to really explore lots of that.
Sounds like a really great opportunity for a new center at Georgia State University, Dr. Lynn. Are there questions from the audience?
Leandris, thanks for a great talk. Really appreciate it. I know you were very much an active leader during COVID pandemic, and I'm wondering, there was a lot of focus on health equity, and that meant there had to be some changes at CDC, structural changes at CDC, and what do you see as the accomplishments from that period? I mean, I remember working with you when the Affordable Care Act came through, and I was in the office of the Assistant Secretary, and there was a mandate around minority health offices, which I thought was really very important, and the Assistant Secretary was a really big supporter of that. So that was a critical time in the work across the nation around minority health. And then we have this major pandemic, and we see all this horrible things happening in communities of color. And CDC had to make some changes. And can you reflect a little bit on what happened and what the accomplishments were?
Yeah, we learned, and I should say we learned again, lots of things about how to address health disparities in communities of color. I think about that period. I describe our office was shot out of a cannon, early on in the pandemic. And, we had the resources, we had the support to do whatever we thought was important, and that was really, really critical. And but what happened after the public health emergency ended, a lot of those structures and systems that had been very, very helpful to us, were essentially, rescinded. So we have the lessons learned. We know what we need to do. We know how we can make a difference. And so we just have to have the ongoing political will to make these things happen. So, whenever chance we get, we talk about our lessons learned. We have gotten a big tailwind from the current administration. And so one of the things that I want, we've kind of gone quickly, because we're we have this space, let's move quickly. So we're trying to take advantage of the moment.
Thank you for that. So, yeah, we have time for one more question.
So, Dr. Liburd, I just wanted to go back to the question Harry did about like partnering with CDC. When I look at those core principles that CDC has put into place in terms of baking health equity into all of the work that they do, like it was all of those topics were really wonderful. But being in a school of public health, whether it's at Georgia State or UNC, how do we actually operationalize that in a way that we are really teaching our students what is meant by those principles? So I think it really just comes down to like, seriously, how would we partner in order to really be able to get that into public health education?
Yeah, so, I think the opportunity is for you to understand within your context what those things mean, right? And then look for ways strategically to embed them. I understand that, words like anti-racism, anti-oppression, some of the other language that we've been privileged to embrace have become trigger words in some instances. But it doesn't mean that you can't really unpack what they mean and then use that knowledge to integrate it into your planning, right? So that you don't have to be, and let me tell you, this is contentious. You don't have to be wedded to the language, but you need to be wedded to the impact and to the outcomes. And so, I think it's going to be critical in the training of students to help them understand that. Because I think what I've observed is we approach our planning, our training, as if like everybody was on our side, that as if the whole world saw these things the way we see them. And that's just not true. And so how do we teach our students to think in terms of how do you counter the opposition, or at least be mindful of it?
Thank you very much. One more round of applause, please. Stay put a second. So didn't mean to box you in the corner here, but I did anyway. On behalf of the School of Public Health, so it's not from me, it's from the School of Public Health, it's my pleasure to give you a small token of our appreciation. And I'm going to remember the last words you said. It's not about the language. It's about the impact and the outcomes. And I think staying true to that is critical. A mentor and colleague of mine, Dr. David Satcher, said that to achieve health equity, we need leaders who know enough, care enough, do enough, and persist until the job's done. And I have to tell you, there's no greater model and example of that than you. So thank you again.